So welcome everybody to the long-awaited 2020-2021 Nursing Research Fellowship graduation. I am very, very proud of the fellows who are graduating in this group because they have shown grit, they've shown tenacity, they've shown persistence. This has been a very challenging year for them to not only be a nurse, but to be a nurse who went the extra mile to ask the hard clinical questions and then go through the process to find answers to those questions. One of the groups is the very first fellowship since I was there in 2013 that had to go through full IRB review. In fact, in the 8 years that I was at Carilion, that was the only nursing research study that had to go through full IRB review. And they did it, and they did it with such style. And so I'm very proud of them. I'm very excited for you to hear their presentations and see the work that they did. And I'm not going to keep belaboring it. It's an exciting day. I bring you lots and lots of congratulations. Beth, was Meg able to join us today?
Yes, she indicated she would be coming on to say a few words.
Okay.
And she is scheduled for 3:05.
3:05. So I need to keep talking for 3 more minutes so I can do that. We also, during a pandemic, I think it was quite remarkable. We had 4 nursing research fellowships going on at the same time. 6, 7, for a total of 10 nursing research fellows. 4 different mentors, and let me say a little bit about the mentors because their work is pivotal. Their work is so very vital for the success of the nursing research fellows. They use their expertise in designing studies, navigating research and development in the IRB, and they guide the fellows very closely at that level of care. And so I thank the fellows mentors for these 2 teams, which were Dr. Phyllis Whitehead and Dr. Ellen Harvey. Ellen was not able to join us today for a very good reason, and I do believe she sent a video. Beth, are we going to be able to play her video sometime during this meeting?
Yes, I certainly hope so.
Awesome. Maybe we can play it right before that, or let's play it right after that group presents.
Okay, sounds good.
That's the plan. So she is here in spirit. She very much wanted to be here, but she needed to be where she was as well. And so she's at someplace very exciting. We'll see if she announces where that is in her video as well. So Beth, if you'll just let me know when Meg joins. The other person that I think is very, very important to thank for the success of the fellowship is Beth Assanay. Beth does a tremendous job in keeping everything straight, sending out all the meeting invites, getting all the materials together, keeping the materials together. She is a point of contact for the mentors, the fellows, and the unit directors. And so her support and work is just so very important and critical for the success of the fellowship. So thank you also, Beth. And lastly, I'd like to thank the unit directors and senior directors because their support is also very important. They have to help navigate scheduling the fellows so that they can have time away from patient care to focus on navigating their studies, and they have to be visionary. They have to be able to support doing something more than staffing. So finding those better ways and answering the questions that the staff had. So I'm again very grateful to the unit directors and the senior directors also for their exceptional work, going above and beyond. And so I'm going to probably mess this up, but I'm going to give it a shot. So our unit directors supporting the fellowship were Russell Beggerly, Brandy Bailey, Robin Clark,
Olga.
And Olga Robinson. So thank you also to all of you unit directors for your support. I also would like to recognize the support of the Health Analytics Research Team, and that includes both analysts and biostatisticians who have been just so tremendously helpful in getting the data, interpreting the data, analyzing the data. And I see that Ellen Rachel Lockhart is on the call today. Ellen Rachel is just wonderful, so thank you, Ellen Rachel, for your support. And looking to see Sarah Boda was very supportive, and they will be recognized in the fellows presentations as well. I do believe Meg is on the call now, and I also would like to acknowledge Meg Scheffel's support for the fellowships. This is something that the Carilion budgets for and allows to happen through the budget. And again, it helps support nurses being able to answer their clinical questions that they're asking. So without further ado, I will hand over the podium to Meg, and then we can go straight into our presentations.
Hi, everyone. Thank you, Kim. That was so nice. So nice to hear your voice still. This is great. I was just getting back from vacation, and Dr. Carter's last day was last week. So I missed saying goodbye to her in person, but Kim, I'm so glad you can join us today. And thank you for all your leadership and support and guidance and mentoring, even to me, throughout the years at Carilion. It's been wonderful. Great journey. For all of our fellows today, I can't tell you enough how much I appreciate your sense of inquiry, your desire to explore and advance our practice. Phenomenal. It gives me goosebumps. And if any of you have attended our nursing orientation, one of the big things I continuously say in nursing orientation is never lose your sense of inquiry. Continuously ask why or why not. And you all have taken that sense of inquiry to new heights, new levels. And I can't thank you enough for your dedication to advance our practice and keeping that sense of inquiry alive. And your research, the research, whether it's true research, and in this case it is, and QA/QI, there's been so much that have come out of the efforts of this department and this type of a program that continuously impacts positively our practice and our patient outcomes, and to some extent even provider practice and patient outcomes. So it's been wonderful. I want to thank each and every one of you. It's been truly a very challenging year, actually 2 years in the milieu of healthcare, and you kept your course. So thank you very much, and I look forward to your presentations here.
All right. So which
are you on mute? Oh, okay.
I believe we're going first with Sandy Hubbard and Kaylin O'Connor, if I'm not mistaken. They may be working on sharing their screen.
Good afternoon, everyone. Our presentation today is on nursing work-related anxiety in the intensive care unit and aromatherapy. We did a blinded, randomized, placebo-controlled trial. Nurses report that factors that increase job-related stress are moral distress, increased workloads, increasingly higher patient acuity, physician communication struggles, and poor leadership. Nurses who experience high levels of stress for long periods of time are at increased risk of psychological issues such as depression and low self-esteem, as well as physical symptoms such as increased blood pressure and cardiovascular disease. They are also more likely to leave their current position or leave the nursing profession altogether. Intermittent stress poses little threat to the body. However, when stress is experienced for long periods of time with moderate to severe intensity, anxiety can follow. Anxiety is defined by the American Psychological Association as emotion that contains feelings of tension, uncontrolled thoughts of worry, as well as physical changes, such as high blood pressure. Research indicates that nurses who have higher resilience and a larger arsenal of coping mechanisms are better able to cope with work-related stress and are less likely to experience symptoms of moral distress and burnout. Aromatherapy is defined as the safe and professional use of essential oils, which are extracted and processed from a plant's bark, flower, root, peel, or leaf. Clinical aromatherapy is the practice of using essential oils for specific quantifiable effects on the human mind, body, and spirit. The American Holistic Nurses Association supports the holistic practice of aromatherapy. Holistic approaches to managing anxiety in the healthcare setting have shown to foster good health behaviors, create resilience, improve nurse-patient communication, care, and satisfaction. There was only one Level A quality systematic review article we found in current literature. Of the 10 articles within this one systematic review, 6 were relevant to our literature analysis. 4 of the studies within this systematic review article conducted aromatherapy intervention and reported a beneficial effect on the stress of nurses. 2 studies used aromatherapy massage. One of the 2 showed statistical significance before and after intervention, showing aromatherapy massage has positive effects on stress level reduction in nurses. The other study showed no difference in stress level of nurses, however, anxiety was reduced. There were 5 articles on lavender. 3 studies had good sample size. The delivery methods were topical application and inhalation. All participants showed decreased stress. However, time away from patients to participate in aromatherapy study may have been a factor for some nurses. There was a quantitative quasi-experimental pilot study on bergamot, which set out to find if there was a link between bergamot essential oil aromatherapy and well-being in a clinical waiting room. The experimental group reported a 48.77% higher scores of feeling proud and 43.36% higher scores in feeling active, but also a 60% increase of feeling nervous. This could potentially be due to the situation of awaiting an appointment. The results showed no adverse effects, which indicate that there is considerable reason to support the safety of aromatherapy in a clinical setting. A study by Donaldson diffused a blend of oil, including bergamot and sweet orange, in a nurse's station. No significant differences were noted in nurse anxiety scores during the intervention period. However, investigators noted a positive attitude among staff toward the use of aromatherapy on the nursing unit. One study was found evaluating the effectiveness of Lang Lang. This study did not specifically target nurses, but it was included in the literature review due to the limited research available on Lang Lang. This was an experimental design using inhalation as the delivery method. While no concrete conclusions were drawn, the study noted a trend toward decreased heart rate and blood pressure, and an increased trend in subjective feelings of alertness and attention. There are several limitations to the existing knowledge regarding use of aromatherapy to reduce anxiety in ICU nurses. Most studies within the current literature show that aromatherapy can reduce nurse stress and anxiety. However, the number and quality of studies is still limited as aromatherapy continues to grow within the knowledge base. Further research is needed to explore the effects aromatherapy has on nursing stress and anxiety. Of the studies reviewed, many had small sample sizes, lack of a powered sample, or low levels of evidence. Some of the studies also had limited control. The purpose of this study was to examine the impact of aromatherapy use on anxiety reduction in ICU registered nurses. This was significant to us because the COVID-19 pandemic has exacerbated nurse turnover, frustration, and anxiety. Recently, the Carilion system has seen an increase in ICU nurse turnover. For fiscal year 2021, there was a 23.47% turnover rate, up from 17.46% in 2020 and 14.3% in 2019. There's also been an increased focus on reducing anxiety and improving staff well-being, and some staff are open to aromatherapy use. For this study, our PICO question was, in ICU registered nurses, what is the effect of aromatherapy with an essential oil blend containing lavender, bergamot, sweet orange, and ylang-ylang compared to placebo on perceptions of work-related state anxiety over a 30-day period?
Sandy, it's not giving me the option to click, so if you'll just click for me, I'll start reading, okay? All right, so this was an IRB-approved randomized blinded placebo-controlled study. The setting was a level 1 trauma academic medical center and a level 3 trauma community hospital. The sample size was registered nurses working in 5 adult ICUs and the neonatal ICU at CRMH, and then the ICU at CNRV. Recruitment was conducted by email distribution via REDCap. Our recruitment emails provided a succinct introduction to the proposed study, followed by REDCap link with 4 screening questions. The screening questions included, are you pregnant? Is there a chance you could be pregnant? Or are you considering pregnancy in the next 90 days? Or are you nursing? Do you have a history of asthma or reactive airways? Do you have a history of allergy to lavender, bergamot, sweet orange, ylang-ylang, or normal saline? Do you have a history of skin or respiratory reactions to inhaled essential oils? Potential subjects were then contacted by the study coordinator to review the study and obtain consent. For our measurements, we started with a pre-survey where nurses were asked to complete a demographic study, asking basic information such as their age, their gender, education, type of unit, shifts worked, years of experience, and certifications. Next, they were asked to complete the state trait anxiety inventory for adults. This is a 40-question survey. 20 questions are for state anxiety and 20 questions are for trait anxiety. The state trait anxiety inventory for adults is a validated tool that we use to measure anxiety. It clearly differentiates between the temporary condition of state anxiety and the more general and long-standing quality of trait anxiety. Its purpose is to determine anxiety in a specific situation and as a general trait. The target population is individuals age 16 and older that have at least a 6th grade reading comprehension. It has an internal consistency coefficient ranging from 0.86 to 0.95, and retest reliability coefficients range from 0.67 to 0.75 over a 2-month period. The post surveys consisted of the same state trait anxiety inventory for adults, as well as an inhaler use log and questionnaire. The inhaler use log was a handheld notebook that was provided to each participant to record the number of times the inhaler was used during the day. Other observations could be recorded if the participant desired, such as pleasant or adverse effects or symptoms when they use the device. The notebooks had no identifying information and were not returned to the investigators. The inhaler use questionnaire was 7 questions asking total number of times the inhaler was used, whether other staff noticed the aroma and when they were using the inhaler, if they had any unpleasant side effects, if they used essential oils outside of this study, if they used the inhaler outside of work, if they participated in any other aromatherapy research studies during the intervention period, and then an open-ended question for any comments they'd like to share about how they felt during the study. All surveys were administered through REDCap. All right, this is our timeline. From starting in May, we started with screening eligibility, recruitment, and consent, followed by June and July, where we consented and had them complete a pre-survey. July to August was when we received the aromatherapy devices and instructions for their use. August to September was our intervention period where they used the aromatherapy device for 30 days. And then from September to October, we had them complete post-surveys, did our debriefing, and followed up with placebo subjects. For our intervention, our biostatistician randomized the consented subjects to either the placebo or the intervention group. The subjects then took the pre-survey, and then to maintain blinding, the study coordinator delivered the devices to the subjects in a bag that contained a pocket notebook, aromatherapy device, a label with their name to apply to the device, and then brief instructions for use and safety in the clinical area. So here is images of our 2 study devices. The intervention device was a personal wick-shaped inhalation device with an aromatherapy blend composed of high-quality essential oils, including lavender, bergamot, sweet orange, and ylang-ylang. It does not contain any added chemicals or perfumes. The components are generally recognized as safe for their intended use. Use of intervention aromatherapy devices was anticipated to be minimal risk with low probability of risk, discomforts, or harm. If a subject had a true allergy reaction history to essential oils, the intervention would be contraindicated and then they were excluded from the study. Then the other device is our placebo device. It's a personal disc-shaped inhalation device, and it just contained normal saline. The company we used for the devices was established by a certified registered nurse anesthetist who developed products for symptom management in post-op patients, including nausea and anxiety. Therefore, this product was selected because it's been used in prior studies safely in a healthcare setting. For our intervention period, the 30-day study intervention period began once all consenting subjects received their device training, and the pocket notebook. Subjects received an email with official start and end dates of intervention period. Subjects were instructed to use their device as often as they wish during the intervention period, and then just record their use in the notebook along with any observations about how the device made them feel. Our team conducted safety data monitoring on days 7, 14, and 21. At the conclusion of the 30-day intervention period, subjects were asked to complete the post-survey and answer the questions related to their use of the device. Then debriefing emails were sent to subjects. During the debriefing, participant subjects were informed of the study completion and that they may keep their device for personal use. They were also informed that the device is not intended for continued use while working at Carilion facility and that the product's good for 6 months. They were also provided PI and IRB contact information. Subjects received the placebo were then contacted via REDCap email using an IRB-approved script and offered the intervention device upon study completion. 5 of our placebo subjects requested the intervention device. The debriefing was conducted by our study coordinator to maintain blinding.
For our data analysis, descriptive statistics such as frequencies and percentages were used to characterize the sample demographic data. All continuous data was presented as means with standard deviations and medians with upper and lower quartiles, and all categorical data was presented as counts and percentages unless otherwise specified. The dependent variables of state anxiety and trait anxiety scores as measured by the STAI were examined using t-tests to determine differences between the intervention and placebo groups pre-study and post-study. Missing data was not substituted, and all statistical tests were performed at the alpha equals 0.05 significance level. The sample characteristics are displayed in the table. 23 nurses took the pre-survey, however, only 18 completed the post-surveys. In order to conduct paired t-test analysis, data from the 5 nurses not completing the post-survey were excluded. 10 nurses participated in the intervention group and 8 nurses were in the placebo group. The majority of the study sample was female. The mean age was 35. They were BSN prepared, worked in adult ICU setting, and worked at CRMH day shift. The median years of experience in the intervention group was 4.5 years, and in the placebo group was 6.5 years. There were no statistically significant differences in the demographic characteristics between the intervention and the placebo groups. Our first objective was to evaluate the effectiveness of inhaled essential oil blend on state anxiety of ICU nurses versus the placebo. Our results: although there is limited published data on normative registered nurse anxiety scores measured with the STAI, recent literature suggests scores between 40 and 59 are indicative of moderate anxiety in adults. The mean state and trait anxiety scores for the nurses in this study ranged between 34 and 44, with standard deviations about 7.5, suggestive of moderate anxiety levels in the study sample. The placebo subjects appeared to have lower raw mean pre and post STAI scores than the intervention group. However, there were no statistically significant differences between the intervention or placebo group mean pre or post STAI scores. Additionally, the STAI mean differences within paired intervention and placebo samples did not meet statistical significance. A reduction in the paired trait anxiety mean scores in the placebo sample from pre 38.875 to post 33.625 approached significance at 0.0586. Our second objective was to evaluate the relationships between age, gender, years of experience, shift worked, and trait anxiety with state anxiety using regression. The results: regression analysis was not conducted due to the absence of statistically significant findings in bivariate analysis. Additionally, our small sample size was a limitation for regression analysis.
We recognize that there were some limitations to our study because this was a single center study and with a sample size insufficient to reach power. Study subjects may have been involved in other aromatherapy-based studies and or stress reduction interventions during the study period in the same setting. While our nurses reported that they did not participate in any other aromatherapy studies during the intervention, there are interventions occurring in the hospital such as Code Lavender that may not have been considered. Nurses may have engaged in their own stress relief practices instead of or in addition to the intervention we were studying. Daily changes in the environment of care could have played a role in the anxiety of nurses felt at any given time. With nurses changing jobs or not coming to work, inconsistent staffing has been another challenge. Not knowing whether there would be 3 nurses on shift or the necessary 5 to 6 could cause a great deal of uncertainty from day to day for these nurses. Changes in patient condition during a given shift or over consecutive shifts are also affect anxiety. If a patient deteriorates, they may have feelings of anxiety or inadequacy, whereas if a patient improved, they could have a sense of well-being and accomplishment. It's also possible that those who chose to participate in this study may have a bias in favor of aromatherapy use. One of our biggest limitations was the COVID pandemic. It's been a huge cause of anxiety. Conducting a study during a pandemic, even a study designed to reduce anxiety, could have been a factor in our recruitment efforts. For our conclusions, we found that this study suggests that ICU nurses at Carilion may have moderate levels of work-related anxiety. We also found that it's difficult to conduct a placebo-designed study using aromatherapy. As noted in several of our free text portions of the post-survey, several placebo participants indicated that there was no smell to their device. There's a dearth of research on the impact of aromatherapy on nurse anxiety in the clinical setting. This study is the first randomized placebo-controlled blinded study serving as a pilot to explore the impact of aromatherapy on anxiety in ICU registered nurses. Additional research is still needed to evaluate the impact of aromatherapy on reduction of nurse anxiety in a variety of settings. For recommendations, we recommend a longer recruitment period and different recruitment methods that may result in more participants. For future studies, researchers might want to explore opportunities for scented non-essential oil placebo alternatives. And although the sample size was small, 23 nurses safely used the device in the clinical setting. There were no untoward events noted during the safety monitoring process. Use of personal aromatherapy inhalation devices might be a safe, low-cost self-care intervention in the clinical setting for nurses. Only one subject indicated that someone else noted the scent. And then last but not least, for our acknowledgements, this is just a list of people that we want to thank for helping us complete this study. This study would not have been possible without all of your contributions, and we just want to say thanks.
Outstanding work, Kaylin and Sandy. And a great presentation. Thank you so much for sharing that with us. Does anyone have any questions for this group?
Question for, this is Meg. Thank you so much. It's very informative. I've been doing some research myself, like literature exploring, I should say, on bergamot and with migraines and stress-related migraines. So I was very curious to hear your findings. Have there been some discussions on next steps of this? Are you thinking you'll take it another step based on your findings, the slide towards the end?
I think we're still discussing what our next steps are going to be. We would like to try to get it published somewhere and kind of go from there.
Well, I'm happy to. I think we should really make sure we post this on our nursing website, maybe get some additional feedback that are questions that might help guide our next questions and inquiry down the line. Well, thank you very much. That was great.
Thank you.
Thank you.
And I see some congratulations and appreciation in the chat, so you'll want to be sure to take a look at that. Let's go forward with the next presentation, and so that will be Mary and Laurel and Amy, and their mentor was Dr. Phyllis Whitehead. So I'm going to turn it over to you.
Beth, are you able to share our slides that we sent with you to you?
Absolutely. Hold on one sec.
And you can just push play if you don't mind just clicking when we say
Sure.
slide.
Absolutely.
Awesome. Okay. Hi, everybody. My name is Mary Conkling, and I worked with Amy Jeffries and Laurel White. And yeah, I bet there's a way to just show the whole. Here we go. Great. Perfect. And Dr. Phyllis Whitehead was our mentor. And so our project was on the impact of moral distress consults on mitigating moral distress experienced among acute care providers working during COVID-19. So that's it. Slide. So Carilion offers moral distress consults. It's something that maybe we realized that not every individual knows about here at Carilion. They are available for any unit within the hospital. And the three of us were curious about the impact these moral distress consults had on mitigating moral distress among our peers. So that was sort of where we started when we were starting this project. Slide. Let me see, Beth, if I can. Beth, do you mind clicking to the next slide? Thanks. Moral distress has become a hot button topic over the past year. It has really been brought to the forefront in healthcare and has gained significant attention. One of the reasons behind this is that it is uniquely personal and often difficult to quantify. It is something that many people experience, but when asked to categorize or quantify it, they often struggle. As this definition highlights, there are some either internal or external factors that are acting upon the individual, constraining their actions. Moral distress is unique for each individual, so the point at which a person experiences moral distress varies. Slide. Moral distress is directly linked with lower retention rates, workplace burnout, and higher patient to staff ratios. These three benchmarks are often seen as classic symptoms of workplace moral distress. Oftentimes, these hallmark signs will appear before an individual even realizes they are feeling morally distressed. They will begin to feel burned out at work. The individual may begin looking for a new job, and the transition in staff will impact staffing directly. Slide. So our study initially started back in 2019 when the three of us got together. Laurel, Amy, and I were having some initial meetings back in 2019 about wanting to do a fellowship project. All three of us work in an ICU. We work in different ICUs, and we were seeing day to day the toll that the acute care setting was having on our colleagues. Being an ICU nurse can be incredibly rewarding, but it also can be a very hard and depressing and isolating place to work. Oftentimes, we would watch our patients become sick, and you realize that no matter the number of interventions, there is little that can be done for them. We initially proposed doing a study of moral distress in the ICU, but once we finally got started in the fall of 2020, we realized that COVID was directly impacting our units and intensifying moral distress in a very unique way. Eight Mountain ICU was one of the initial COVID ICU units, and as we saw surges, they would send some of the surge volumes over to 9 South ICU, which is where Laurel and Amy worked. So we were directly feeling the impact of COVID, not only in our patient population, but from our staffing side. For our initial research, we could tell that in the initial 6 months of COVID, so back in the fall of 2020, there hadn't been any direct study on moral distress on ICU patients. We did find research that said the individuals providing care for COVID patients were experiencing exponentially higher rates of moral distress, but that there was no concrete examples of interventions that had been used at that point in time. So we identified a gap in literature, and we were eager to see if we could learn something through our study. When we were initially planning just to study moral distress on a general topic and the impact it had with moral distress consults, we saw that there was a lot of literature about moral distress. It is an issue that is very prevalent to healthcare, and I understand why it directly impacts the way that we do care and the way that care is provided, the finances on the hospital system when you look at turnover rates and burnout. But there aren't a ton of solutions per se with interventions on how to do that. And that has only been exacerbated over the past 20 months with COVID-19. So, slide. Working on our units, we noticed a huge shift happening. Individuals were leaving the bedside. They were feeling burnt out. They needed to step back from COVID. They needed a break. This in turn impacted the quality of care they were able to provide as we were able to provide as patient staff ratios were shifting. Moral distress often does impact patient safety. Providers experiencing moral distress may not be as quick to respond to changes in patients. We saw this shift happening and we wanted to see if moral distress consults could help mitigate this and provide a unique way of unifying and supporting the staff. The moral distress consult became a unifying platform where each individual, while experiencing moral distress differently, can find a community amongst their peers who may also be experiencing moral distress. One important factor that we realized is that some of our individuals who we were looking at had experienced a moral distress consult before, while others had not. And I think that individuals we noticed who had experienced a moral distress consult were more interested in participating again and seeing the impact it had on their care and their study. Slide.
Thank you, Mary, for sharing. I'm going to share the next few slides. We were very thankful that we became IRB approved after we had done numerous data research, article researches. It was, as we stated in the beginning, our research project actually was frozen a bit due to COVID. But we were very eager and excited to really be groundbreaking so far as talking about moral distress among COVID. And as most people know, the impact that COVID has caused a lot of nurses, not just directly with those that are on the COVID units, but by anybody that works in the healthcare setting. We were very fortunate that when we first started, 8 Mountain ICU was the only COVID, and then we became the overflow. So our idea was that it would hopefully increase our data results in our population of what we were researching. So next slide, please, Beth. So we came up with our PICO question, and our research question was, what is the impact of moral distress consults on levels of moral distress as determined by the moral distress thermometer and the HEC short form experienced by individuals providing direct patient care for COVID-19 patients on 8 Mountain ICU and 9 South ICU since March 2020. We are very fortunate that we have Dr. Whited as part of our Carilion Clinic healthcare system, and as well as she became our mentor. And she has direct works with the moral distress thermometer and does an excellent job so far as being able to provide these moral distress consults. Next slide. These are some of the methods that we decided that we were going to use through this. We did a mixed method study using a convenience sample from both of the units. We decided not to just make this specific for nursing. We opened this up to all clinicians that had worked on the units since March 2020. And as I discussed earlier, we used the two specific tools, which is the moral distress thermometer and the Olson HEC short form, which I'll go into detail on the next slide. The participants, through the help of REDCap, we were going to have to do 3 surveys. There was a pre-survey, a post-survey, which was to take place immediately after the consult, and then one that is 30 days out. And then the data was collected in pre and post consultation environments and is going to be analyzed in the future. To the right of the screen is what the moral distress thermometer looks like. And we were fortunate enough to be able to use this tool. So, next slide. As I stated, we used what was called the Olson's HEC short form. It's actually a 14 questionnaire used to gauge the ethical climate within the organization. And when Dr. Whited did this consult, she used the short form. This tool uses a 5-point gradient scale from never true to always true, allowing individuals to determine within that range. And then the moral distress thermometer was a 10-point scale that spans from 0 to 10, and individuals will be asked to identify where on the scale they lie at that exact moment. And this is what we had asked our clinicians that participated in the study to do. Next slide. These were some of the demographics that we used to conduct this study. Some of the things that we needed to collect data-wise was the age, how many years of service have they served at Carilion Clinic, what was their current position. As I stated earlier, we opened this up to anyone that had worked on the unit since March 2020. And then we also wanted to know, were they currently caring for the COVID-19 patients? And a unique identifier that we used was their Carilion email. These surveys were opened up by scanning a QR code or a link that was sent to them from the unit directors. And the way that we could identify them was, again, through that email. Next slide.
All right, thank you, Amy. My name is Laurel White. For the procedures, the moral distress consults, as Amy said, were led by Dr. Phyllis Whitehead. Each unit identified a specific time for each moral distress consult. One was offered for each unit. The participants opted into the study by completing the pre-survey that was given before the consult. And additionally, there was 3 surveys total that were given. It was the pre-consult survey. There's an immediate post-consult survey, as well as another survey survey 30 days outside of the consult. Data analysis, descriptive statistics will be conducted on the demographic data using mean, median, standard deviation, IQR, and percentages. The change in the MDT scores and the HEX scores over the 3 time periods will be analyzed using either the repeated ANOVA test, which is just an analysis of variances, or the Friedman test, which is an alternative to the ANOVA test, and it tests the differences between the related samples. Additional comparisons that will be used is t-test or the non-parametric Wilcoxon test, and both just kind of show the difference between the means of the 2 groups. Additionally, all the tests will help us find out whether the differences between the groups of data are statistically significant. We used Heart Services for data management. REDCap was used for data collection. It helped keep the data organized as well as protected. As Amy said as well, each participant was given unique logins. It helped keep them anonymous, as well as helped track changes across the 3 surveys. QR codes and survey links were sent out through the email for each participant. Following the 3rd survey, we'll use the demographic questions and the 2 tools to answer the proposed research questions. So our data collection is actually still in process. We were able to do the 2 separate moral distress consults for each unit. We had a sample size of about 14 participants. Every participant had provided care for COVID-19 patients. Ages ranged from 24 to 52 years old, 1 to 20 years of service at Carilion, and then they all had about 8 to 20 months of providing care for these patients. Some lessons learned from this project. A lot went into developing this study, and we are so very thankful and fortunate for Dr. Phyllis Whitehead and her mentorship. For the research process, we all 3 felt like we were experiencing moral distress on our units. We were seeing it within our peers. And we wanted to try to find a solution to help with that. So we found a problem, which was moral distress, formulated a PICO question. We all had to go through city training, as well as sitting down and going through literature reviews. Approvals, we had to wait for approval from the R&D with Carilion, as well as the IRB. And then before we could even implement the moral distress consults, we had to wait for approval from the unit directors before we could start. Also, we decided to do a project during a global pandemic. So that was a little bit of a barrier for us, because not only were we, living our own personal lives, but we were working extra hours at work, and between the acuity of the patients that we were seeing and then the staffing shortage we were seeing as well, it could get a little overwhelming for us. But we were still wanted to persevere with this study because we were living what we were doing the study for, and that was our whole goal, was to figure out a way to help our peers. We just want to say thank you to everybody for your encouragement. Dr. Kim Carter, Dr. Phyllis Whitehead, Dr. Brandy Bailey, Dr. Tanya Locklear, Dr. Maria Henke, and also to Beth for keeping us on task all the time.
This is really great work, and I know that you've got work left to do, and I thank you for continuing to work on your data analysis and disseminate. Both groups, dissemination is super, super important once you finish your studies, so don't forget that important step. Phyllis, do you have anything you would like to say to your group?
Thanks, guys. I've been listening to everyone. I'm so proud of you guys. It has been one heck of a journey. Yes, we've all experienced some moral distress. I don't know. I may have to actually study to see if conducting a study is a source of moral distress. I don't know, guys. But I loved working with each and every one of you, and know that we're going to continue to work as we collect the data and analyze it. And you bet, Kim, I'm going to make certain that these ladies disseminate. So I couldn't be prouder of you all. So thank you. And thanks everyone for being here and listening to these, to the presentations, and congratulations to the other group too. It's wonderful. And aromatherapy, love it, love it. We'll have to collaborate on moral distress and aromatherapy somehow with collaboration. Thanks, guys. So proud of you.
So it looks like we have a question. Brittany Spencer has raised her hand. Brittany?
No, that was a mistake. I meant to do a hand clap. They did a great job.
Like hand claps too. That's awesome. Does anyone else have questions for the group? All right, well, we're going to do a little experiment here, and Beth is going to try to show a video for Dr. Ellen Harvey to share her remarks for the aromatherapy group.
Yeah, I'm sorry, because of the format it's in, I couldn't actually upload it to be shown here. So let me see if I can just do it with my phone. I don't know if you guys are going to be able to hear it. Let's see.
Specialist at Carilion Roanoke Memorial Hospital for inpatient surgery, and have had the honor to serve as the mentor for the nursing work-related stress in the ICU and aromatherapy nursing research fellowship team. The aromatherapy fellowship team members, beginning with Sandy Hubbard, who served as the primary investigator, I have to be honest, is one of the finest researchers I've had an opportunity to work with in my career. And Kaylin O'Connor is a fantastic problem solver, consistent and reliable every time to get things done and get them done really well. Taylor Brogan is a very pragmatic person, was always resourceful in finding solutions for the study. Together, they've made a dynamic team, and it's been an absolute honor to be their mentor. I would also like to send out a special thanks to Ellen Rachel Lockhart as the data analyst and biostatistician, and Sarah Bodo, who served as the study research coordinator, for their outstanding contributions to the study. This study is the first nursing research study at Carilion to be a randomized placebo-controlled trial that went to a full institutional review board review during a global pandemic. And that is no easy task, truly incredible team. The challenges were tackled by this team with determination, flexibility, and grace. This study sets some important groundwork for future studies exploring the potential role of aromatherapy in supporting nurse resilience and wellness. The fellows did a phenomenal job implementing, designing a very complex study, and I have to be honest, I learned a great deal myself participating in this study. And thank you once again for the opportunity to be your mentor. Nursing Research Fellows, enjoy your special graduation day. I'm very sorry I wasn't able to be there today, but congratulations to all the graduates of the 2020 Nursing Research Fellowship. Have a great day.
All right, can everybody
That's
hear that
great.
all
Thank
right?
you. Yeah, thank you so much, Beth, for making that happen. Chris, I'm going to hand it over to you, as I've done for the entire office, and let you take it away.
Thank you, Kim. I would like to point out that this graduation is being recorded and will be uploaded to the Nursing Research Conference. So for those who view it during the conference, I'd like to point out that you can find more information about the Nursing Fellowship on Inside Carilion under the Nursing Research and Evidence-Based Practice Department. I too would also like to thank everybody for attending. You all, the fellows, Laurel, Amy, Mary, Sandy, Kaylin, and I think Taylor was not able to come, but you've all made a huge commitment into your studies. And we mentioned more than once the pandemic leading to challenges. And I'm amazed that you're able to find the time and energy to conduct these studies and to help others who are on the front lines caring for patients. The mentors, Dr. Phyllis Whitehead, Dr. Ellen Harvey, you two, the energy, the time and energy during these times of a pandemic to be able to mentor and guide these folks through their project planning, data collection, analysis, and on to dissemination. Your skill sets are invaluable. And the unit directors, managers, you all are being challenged by staffing and other priorities, yet you were able to support these guys to get their projects done. Beth, we have a plaque.
Yes. Hopefully you can see a little bit of it. Your name, can you see anything at all? Probably not.
It's kind of a blob, but
it's going to be hanging outside of Chris's office down here in Nursing Administration. All of your names are on it and the dates that you graduated. So feel free to come down anytime and see your name or take a picture of it. If you'd like, I'll take a picture and send it to you, either one you want. And we also have your pins. I'll be sending you these pins in the interdepartmental mail with your certificates. You can put them on your badge. They're really nice. Kim, I think there's a little story about this. I think these are the ones that the original group voted on. Is that correct?
So when it was not the original Nursing Research Fellowship group, but it was a group in 2013, and we surveyed them and let them select the pin, and this is the pin that they selected. So it is selected by some of your predecessors in the Nursing Research Fellowship, and wear it with pride.
And the plaque immortalizes you in the halls of Carilion. It's a lasting reminder of your efforts. So congratulations, all of you. Best of luck as you wrap up your study or as you prepare to disseminate. I'm here to help if you need assistance with editing or whatever. Feel free to reach out.
Great job, everyone. And you guys have a good afternoon.
Thank you, Beth.
Thank you.